Welcome to Didactic Child and Adolescent Psychiatry Edition. Today is Tuesday, May 20th, 2025, and I am your host, Dr. O'Leary, a fellow in child and adolescent psychiatry in the National Capital Region. I started this podcast feed to help me study for my board exams, and I hope it helps you as well if that's what you are doing, but anyone else interested in human development or mental health might also enjoy the content. I need to let you know that everything that I say here should be considered to be my own opinion, even if I'm quoting or referencing someone else or some other institution. Additionally, I've been learning how to use AI to assist me with the content creation and research. Specifically, for this episode, I used Gemini's deep research tool to produce a detailed overview of pediatric anxiety disorders, and then consolidated that information into a podcast script that includes my own content merged with the AI content. I used my own background knowledge as well as spot checking of facts, especially the numbers that it likes to generate, to make sure that the AI isn't just making stuff up. Like humans, AI makes mistakes, confabulates, hallucinates, but I've found it recently to be at least or even more reliable than much human-produced content. Previous episodes have also used AI-generated hosts to deliver the content, but I find that I learn the content better if I host the podcast myself. So for topics like anxiety disorders that make up between 7 to 9% of the ABP and board content, I want to be more intimately involved with the production of the content. So today, in this episode, I'm covering separation anxiety disorder, selective mutism, specific phobias, social anxiety disorder, panic disorder, agoraphobia, and last but not least, generalized anxiety disorder. But first, let me make this a little more practical. I'm going to present a couple case vignettes, and I want you to think about the most likely diagnosis. An 8-year-old girl, Maureen, is brought to the clinic by her mother due to a 6-week history of refusing to attend school. Each morning, Maureen cries, clings to her mom, complains of severe headaches and nausea. She repeatedly tells her mom, "I'm scared something terrible will happen," when her mom is away from her and she may never see her mom again. Maureen has also had significant difficulty sleeping alone, often needs someone to stay in her room until she falls asleep, and then gets up in the middle of the night and goes to bed with her parents. When she finds herself alone in a room playing at home, she frequently calls out to her mom and then goes to look for her. She has always had that difficulty sleeping alone, but the school avoidance and frequent reassurance seeking started shortly after her mother had a brief, uneventful hospitalization for a minor surgical procedure. Maureen's grades have started to decline, and she has stopped attending friends' birthday parties and after-school activities that she previously enjoyed. So what do you think? Is this kid depressed? Generally anxious? So the most likely diagnosis here is separation anxiety disorder, because Maureen exhibits a fear of separation from her mother, and the school refusal is due to that fear and not fear of going to school or being around other people. She worries about harm or something happening to her mom. She has sleep difficulties when she's not near her mom, and even has physical symptoms related to the separation, which is very common among children to experience anxiety physically instead of intellectually or cognitively. All of this lasted for more than 4 weeks, and it isn't really diffuse worry about lots of different things like in generalized anxiety. It's not social anxiety's fear of scrutiny from others, and it's not a specific phobia of going to school itself. Now let's look at Lily. Lily's a 5-year-old girl in her first year of kindergarten. Her parents describe her as a chatterbox at home, where she's talkative, expressive, and playful with her parents and older siblings. However, her kindergarten teacher reports that Lily has barely spoken in the classroom or to any of the other school staff since starting school about 3 months ago. She appears to understand instructions. She follows classroom routines. She willingly participates in the nonverbal activities such as drawing and puzzles. When asked direct questions by the teacher or the peers, Lily typically looks down, or remains silent, or communicates with some simple gestures like nodding or shaking her head yes if she needs to go to the bathroom. Her parents confirm her language skills at home are age appropriate, and she has no prior speech or language delays. There is one teacher with whom she has whispered some words into her ear a couple times. So, what's going on with Lily? Here we have a case of selective mutism. She speaks at home but fails consistently to speak at school, and it's been going on for more than a month. It isn't really a language disorder. It's not autism because she can interact socially if she wants, and she communicates fine in other settings. So, this is a case of selective mutism. And as we'll find out soon, selective mutism is highly comorbid with social anxiety disorder. But we'll get to that. Anxiety is a normal part of childhood. Just think about things like the developmentally appropriate separation anxiety in toddlers or a young child's fear of the dark. That's reasonable. I mean, if a child did not display some separation anxiety, we would wonder if there was something developmentally wrong with them. Why aren't you crying when your mom drops you off at the daycare for the first time? But when does this anxiety cross the line into a disorder? In general, pathological anxiety in children and adolescents is marked by its severity and its persistence. 6 months is used for many disorders, though shorter for some, like separation anxiety disorder in kids. And the significant dysfunction or impairment it causes in their daily lives, whether it be at school or with friends or at home, is important. Pediatric anxiety disorders are the most common psychiatric conditions in youth. They affect at least 1 in 12 children overall, and this increases to maybe 1 in 4 adolescents. And these aren't just phases of development that they'll likely grow out of without any help. Untreated anxiety is often chronic, persisting into adulthood, and increases the risk for other conditions like depression and substance use disorders. Sometimes anxiety in children mimics other conditions. A child might be inattentive and restless, kind of irritable, or have frequent stomach aches or headaches. And this can lead to a misdiagnosis, going to their primary care doctor quite frequently, and they're not able to find anything wrong with them, or they might be misdiagnosed with ADHD or oppositional defiant disorder if the underlying anxiety isn't recognized and treated appropriately. So that's why accurate diagnoses and timely evidence-based treatment are really critical for childhood anxiety. Let's start by getting into some of the nitty-gritty details of the DSM and how to diagnose different anxiety disorders. So let's start with separation anxiety disorder. So the core feature here is a developmentally inappropriate and excessive fear or anxiety about separation from their attachment figures. So to diagnose separation anxiety disorder, you need at least 3 of 8 symptoms. These include recurrent distress around the separation, persistent worry about losing or harm to attachment figures, worry about events leading to separation, like getting lost or being kidnapped, reluctance or refusal to go out or to go to school due to separation fears, fear of being alone, even in the home, reluctance to sleep away from home or without an attachment figure at least nearby, nightmares about separation, and quite frequently repeated physical complaints like headaches or stomach aches when separation is anticipated or when it occurs. So a key child-specific point for separation anxiety disorder, and it is most common in children and not really in adults, is the duration. So it must be at least 4 weeks in children and adolescents. If you're going to diagnose it for the first time in an adult, it had to have been present for at least 6 months. And of course, it has to cause clinically significant distress and impairment. I mean, I doubt a parent would be asking you to evaluate a child with 3 of these 8 symptoms if it wasn't also causing distress. But just in case you incidentally found out that they met 3 of the 8 criteria and there's no reported impairment, well, then you shouldn't be giving the diagnosis. You should just maybe monitor and provide some reassurance and maybe even some CBT-based treatment to prevent it from becoming an actual disorder. Next is selective mutism. This is characterized by a consistent failure to speak in specific social situations where speaking is expected, like at school, even though the child does speak in other situations, for example, at home. It can't be due to a lack of knowledge of the language, for example, when learning a second language, and it can't be the result of a communication disorder. See episode 13 of this podcast for a rundown on that. Also, this disturbance must last at least 1 month. And not really just the first month of school, like a month and a day, and then it went away, but persisting for more than a month. And it has to interfere with the educational achievement of the child or with their social communication. Almost by definition, it does interfere because they're not interacting. Someone who's creative might imagine a situation in which someone could have selective mutism and it not interfere with their achievement. Now, onset for this is typically before age 5, and it often comes to clinical attention when school starts. Because before this, some kids, especially those who were 3 or 4 during the COVID pandemic, had not really had a lot of opportunity to present in environments like this. These kiddos might use frequent nonverbal communication, some gestures. They might even write, but not speak. Next, we have specific phobias. So this involves a marked, persistent, and excessive fear or anxiety about a specific object or a situation. We can call that a stimulus. So think like animals, heights, needles, flying, public speaking. The phobic stimulus almost always provokes immediate fear, is actively avoided or endured, but with intense anxiety. And the fear is way out of proportion to the actual danger here. And it also has to cause significant distress or impairment. So if you're not in an environment in which you're ever exposed to a phobia, it's never going to be diagnosed. It's not causing any impairment for you. My son, for example, loves to fish, but he is somehow terrified to hold a wiggling earthworm. Now, a non-wiggling worm, like a dead one, is okay, but a wiggling one is terrifying to him. So even though earthworms are harmless, it causes him significant distress. But his impairment is really limited to kind of putting the bait on the hook. So I'm kind of ambivalent about calling it a specific phobia because, well, we don't fish for a living. However, it does interrupt the fun of fishing because I'm the one who usually has to bait the hook and prod him to try it himself. And he has frequently hooked his own finger because he freaked out when the worm started to wiggle. So maybe it is a disorder. Anyway, wiggly worms are terrifying to him. In general, the phobias we treat are going to have more severe consequences than not being able to bait a hook with a worm. So for kids, the fear or anxiety is often expressed with crying or tantrums, just completely freezing or clinging to their parent and refusing to let go. It could be they're in the emergency room and they need to get a shot and they elope, things like that. And it's also important to notice that the DSM-5 TR does not have a requirement that an individual, including children, must recognize their fear is excessive. They don't have to recognize it. They could believe that it's perfectly reasonable to have that fear and still be diagnosed with a specific phobia. Next, we have what has been called a specific phobia, a social phobia, but is now more commonly referred to as social anxiety disorder. And I'm not going to call it SAD or SAD because that's just sad. And also, separation anxiety disorder could be SAD or SAD, so that's just confusing. So I'm going to call it social anxiety disorder. And social anxiety itself is a marked fear or an anxiety about one or more social situations where the individual is exposed to possible scrutiny by others, like conversations, meeting new people, being observed eating, or performing. The core fear here is acting in a way or showing anxiety symptoms that will be themselves negatively evaluated. So they will feel humiliated or embarrassed, and this could lead to rejection. So these situations almost always provoke that kind of fear. And so they're avoided or endured with intense anxiety. And that fear is out of proportion to the situation. It also needs to be present for 6 months or more and cause significant distress or impairment. So this means a single incident of a refusal to do something, like speak in front of the class, doesn't really meet this criteria. But imagine that you are an enlisted service member and you want to promote, but you're terrified to go in front of the promotion board. Now, in reality, promotion boards are scary things, and they are actually designed to increase anxiety in people. So it's not unreasonable to be scared of going to a promotion board. But if you're so scared to do it, even though you've prepared and you can't promote because you can't go to that board, well, that would be more suspicious for a social anxiety disorder. Now, for children, the anxiety must occur in peer settings and not just with adults. And like with specific phobias, their anxiety often manifests as crying, tantrums, freezing, clinging, or just failing to speak. So they might become mute in certain circumstances. And for kids who have been diagnosed with selective mutism, there's something like close to a 90, sometimes I've seen as high as 97% chance that they also have social anxiety disorder. So be on the lookout for this comorbidity. Selective mutism is really a harbinger of social anxiety, although social anxiety itself does not necessarily result in selective mutism. It's also important to note that because social phobias and anxiety disorder have similar behavioral expressions such as tantrums and clinging, they can be misread as defiance, refusal, rather than as anxiety. So it's very important to get a thorough history. Now moving on to panic disorder. So the essential feature of panic disorder is recurrent, unexpected panic attacks. These are not attacks where anxiety has been ramping up for some time and they know they're going to freak out. So if a kid knows that they hate public speaking and has a panic attack prior to every instance, this is not a panic attack that counts for panic disorder. This is an anxiety attack. So a panic attack is an abrupt surge of intense fear or discomfort, and it usually peaks within a few minutes. And it has at least 4 of 13 symptoms. Things like palpitations, sweating, trembling, shortness of breath, choking, chest pain, nausea, dizziness, chills or heat, paresthesias, derealization or depersonalization, or fear of losing control or going crazy, or a fear of dying. So that's a lot of things, but you only need to have 4 of them reported. And for the disorder, at least one attack must be followed by 1 month or more of persistent concern about more attacks or their consequences. And this causes a significant maladaptive change in behavior related to the attacks. Often that is not going to places that you need to go to, or not even leaving the house. Younger children don't tend to report cognitive symptoms like fear or this thought they might lose control. They tend to have more physical symptoms. And the APA has a severity measure for panic disorder for kids aged 11 to 17. So all you have to do is Google APA severity measure panic disorder 11 to 17 and you'll find that. Next is agoraphobia. Agoraphobia involves marked fear or anxiety about 2 or more of 5 situations: using public transport, being in open spaces, being in enclosed places, standing in line or being in a crowd, or being outside of the home alone. The individual fears these because escape might be difficult or help is not available if panic-like or other kind of incapacitating or embarrassing symptoms occur. So these situations almost always provoke fear. They're actively avoided or endured with intense anxiety, and the fear is really out of proportion to the situation. Agoraphobia, to be diagnosed, has to last 6 months or more and has to actually cause significant distress or impairment. A key DSM-5 change was with the decoupling of agoraphobia from panic disorder, and these are often very similar, and clinically it can be frequently hard to tell apart, and maybe one can result in the other one over time, but they are now distinct clinical diagnoses. The key difference is the reason to avoid certain situations or leaving the home. If there's more of a generalized fear of public use spaces or open spaces, this is more like agoraphobia. But if the reason you're afraid is exclusively the fear of kind of a random panic attack, then that's more panic disorder. You can also have agoraphobia and specify that there are panic attacks present. In children, the fear of incapacitating symptoms might include things like not knowing where they are or what to do or getting lost. And this is how panic might manifest in them. Finally, the mother of anxiety disorders, generalized anxiety disorder. So the core of this is excessive anxiety and worry about a number of different events or activities occurring more days than not for at least 6 months. So the individual finds it hard to control the worry. The worry and anxiety are associated with symptoms like restlessness, being easily fatigued, difficulty concentrating, irritability, muscle tension, or sleep disturbance. So here's a critical child-specific point. Only one of those associated symptoms plus the impairment is required for children, but you need at least 3 of those symptoms for adults. Children with generalized anxiety disorder often worry about things like competence, their safety, future events, and it can express itself as kind of a perfectionism so that nothing happens. I have to do everything right. Other more vague somatic complaints are also very common, things like headaches and GI issues. Now, with this one symptom rule, instead of the 3 required for adults, kids are more easily diagnosed with generalized anxiety disorder. So it means that clinicians have to be kind of rigorous in confirming that there is excessive uncontrolled worry and some functional impairment, so we don't over-pathologize normal childhood experiences, because kids are going to worry about things and they are going to have some of these symptoms associated with that. So we really have to make sure that what we're talking about here is a disorder. So now let's turn to some of the epidemiology of these anxiety disorders. I think I mentioned before that anxiety disorders are highly prevalent. There's global estimates around 6.5% to 8.3% in all children, and up to even 25% in adolescents aged 13 to 18. And it all kind of depends on who's measuring. But it's probably less than 10% in all children and at as much as a quarter of adolescents. Females are more commonly affected than males, and that's at a 2-to-1 or 3-to-1 ratio. And the etiology of anxiety disorders is multifactorial. Of course, it involves some genetic predispositions. Anxiety often runs in families, and there's often a lot of behavioral inhibition and kind of shyness in the kids. But environmental factors such as stressful life events, parenting styles, and socioeconomic status can contribute as well. Now, if you're interested in how environmental factors contribute to anxiety, listen to or read The Anxious Generation. That's a book by Jonathan Haidt. That's Haidt. And he attempts to explain why anxiety disorders have been on the rise for the last couple of decades, and relates this to anxious parenting as well as the rise of social media. It's a great read, and I highly recommend it. Comorbidity is very common in anxiety disorders, especially with conditions like mood disorders, ADHD, or disruptive behavioral kinds of disorders. So let's touch on the specific epidemiological differences between each. Separation anxiety disorder has a prevalence around 4% in community samples, and it has one of the earliest onsets, often diagnosed around 6 years of age, when children have to be separated from their parents, whether they like it or not, in a lot of societies. Risk factors include family history of anxiety and depression, and especially overprotective parenting. So excessive reassurance given by the parent to the child can increase the child's likelihood of having separation anxiety. It's also highly comorbid with generalized anxiety disorder, with specific phobias and with mood disorders like major depressive disorder. Selective mutism is pretty rare. Estimates are generally less than 1%. The onset is usually before age 5, and it's often identified at school entry, like separation anxiety disorder. Behavioral inhibition and family history of shyness are strong factors as well, and it is extremely highly comorbid with social anxiety disorder. Numbers ranging from 80 to 97% of kids diagnosed with selective mutism will also meet criteria for social anxiety disorder. Now, social anxiety disorder has an estimated global prevalence of around 4 to 5% in children and around 8% in adolescents. And the older you get, it increases up to about 17% in older adolescents and young adults. Social anxiety appears to increase with age, and then it kind of levels off during young adulthood and is often rather persistent. The median onset is around 13 years of age. A history of behavioral inhibition, shyness, fear of negative evaluation by others are all risk factors of developing the disorder. Childhood maltreatment, and especially peer victimization, bullying, also can play a significant role. Obviously, bullying is going to have an effect on whether normal social anxiety becomes intolerable to children if they actually expect, because it has happened to them, that they will be unreasonably criticized by others. Social anxiety is often very comorbid with other anxiety disorders, with mood disorders, and even substance use. Early difficulties in peer relationships can both be kind of a risk factor and a consequence of social anxiety disorder and generalized anxiety disorder. So it kind of creates this negative feedback loop that can reinforce the condition. Next are specific phobias. So specific phobias have a pretty high lifetime prevalence, and there are some estimates at 3 to 15% globally, or 20% in US adolescents themselves. Onsets typically between 7 to 11 years. Risk factors include female gender, shyness, like with other things, but especially direct or some sort of vicarious negative experience with the phobic stimulus. Remember when I talked to you about my son being scared of the wiggly worms? When he was younger, under the age of 7, he wasn't scared of them at all. We used to go out and dig worms, and he would play with them. And then one day he saw his grandmother exposed to a worm, and she freaked out. She's a city dweller, doesn't even like to walk through the grass because of what might be in the grass, and she hates worms. After that, he suddenly couldn't stand it when they wiggled, and it hasn't gone away. So this vicarious negative experience, watching someone else have a reaction, may have been the thing that tipped him into his anti-wiggly nature. Now, phobias of needles and of flying and of bugs in general are super common. And specific phobias have high comorbidity with other anxiety disorders and also with mood disorders. Next is panic disorder. Panic disorder is really uncommon before age 14, so like less than 0.5% prevalence. But it jumps to around 1 to 2% in adolescents. And it's also more common in females, about 3 to 1. It's very high comorbidity with other anxiety disorders, with panic attacks as a specifier you can give to other disorders. But panic disorder itself is more than just having some panic attacks. So it's highly comorbid with other anxiety disorders, with mood disorders, and often with PTSD as well. Agoraphobia is uncommon in really young children, and this is another of those anxiety disorders where as people age, more and more people develop agoraphobia. Lifetime prevalence in US adolescents is only around 2-ish%. And generally, there is an onset of agoraphobia after 20 years of age, and the prevalence continues to increase with age. So this isn't something you see a lot in kids. It's also more common in females. Risk factors include panic disorder, high levels of neuroticism, in general, just finding anxiety intolerable. So therefore, it's highly comorbid with other anxiety disorders and also with Mood disorders, in part because a lot of these folks do not get a lot of good reinforcing social interaction. And lastly, generalized anxiety disorder. Prevalence estimates are between 2.2 and 4.6% in youth. The median onset for generalized anxiety disorder is late adolescence. It's more prevalent in adolescent females. There seems to be a significant genetic contribution, and you'll see this run in families. Temperamental traits like behavioral inhibition, shyness, and negative affectivity are risk factors for generalized anxiety disorder. But environmental factors are also important. Parental psychopathology and stress, like I mentioned before, anxious parenting can result in anxious kids. And just like every other anxiety disorder, generalized anxiety disorder has high comorbidity with other anxiety disorders and with mood disorders. I think it's a good time for a couple more vignettes. So we have David, a 14-year-old boy, and he is referred for social withdrawal and worsening academic performance in the fourth quarter of 8th grade. Now, parents report he's never really been a social butterfly, but this year he's increasingly avoiding things like the school dances, parties he's been invited to, he declines, and he doesn't like to eat in the cafeteria. He brings his own lunch to school and eats in a more quiet place. He's skipped his humanities class recently and failed to tell his parents about a project he was supposed to present last week. They report that once, about a month ago, they had to pick him up from school following a panic attack he had when he remembered that he had left his lunch at home and had to get lunch in the cafeteria. So given this limited amount of information, what is the most likely diagnosis for David? Is it generalized anxiety disorder, separation anxiety disorder, social anxiety disorder, agoraphobia, panic disorder? With the information I have, my highest suspicion is for social anxiety disorder. But it's not a slam dunk. David's core fear appears to be social situations involving peers or even having to present in front of peers. He shows avoidance and distress in these particular situations as far as we know, not others. We haven't been given information about more broad worries or separation fears, which are usually present in younger children. So my next question might be, how often do you think about whether or not you might have a panic attack? Or I could ask, how does he appear when taking public transportation or going to the park? Well, let's move on to Ben. Ben's a 15-year-old boy, and for 8 months, he's refused to accompany his family to crowded places like theaters and concerts, restaurants. He has skipped school when his parents couldn't take him and he was required to take public transportation. He's not sure what he's afraid of, but sometimes has fantasies that the guy next to him will have a heart attack and he'll get trapped by a gathering crowd, or there will be an active shooter and he'll get trampled when trying to escape. He thinks the probability of these events is far higher than it actually is. He has had panic symptoms which tend to build up within him during the expectation of having to go somewhere outside of the home. For example, his parents had to coax him into the car because he didn't want to go to the medical clinic, insisting he was fine. What is the most likely diagnosis for Ben? Is it panic disorder with agoraphobia? Is it a specific phobia, situational type, a social anxiety disorder, or agoraphobia? So Ben is most consistent with agoraphobia. He fears and avoids multiple agoraphobic specific situations like crowds, public transport, enclosed places, and he has thoughts that escape might be difficult if something bad happens. And he also fears that something bad will happen. His fears of what might happen are really not specific to a single situation, so it's not a specific phobia of one situation. It's broader than that. And it's been around for more than 6 months, and he's impaired by it. Since he hasn't even had a panic attack, which is unexpected panic symptoms, he can't have panic disorder. And let's shift gears and talk about some treatments. So the mainstays for pediatric anxiety of all types are various forms of cognitive behavioral therapy with or without pharmacotherapy. In particular, selective serotonin reuptake inhibitors or serotonin and norepinephrine reuptake inhibitors. Combination therapy is frequently best, especially for moderate to severe cases. Let's start with some therapy. Cognitive behavioral therapy is the first-line psychosocial treatment. So the core components include psychoeducation, just learning about what's going on, somatic arousal management, can also be called relaxation techniques, followed by cognitive restructuring, which is the active challenging of anxious thoughts. It often has to include problem solving, like how am I going to do these things that are going to help me get over this? And critically, it includes exposure therapy for anxiety. And this is either the gradual confrontation of a feared stimuli or a more intense but shorter duration treatment of exposure to that stimuli. So parental involvement is really key here. Many parents can't stand seeing their kid in distress, and they will have reinforced their child's fears by allowing them to avoid the situations that they're afraid of. This is super common. I mean, many kids with anxiety will learn to cope with it if there is no other choice, but if a caregiver becomes anxious about their kid's anxiety, that is extraordinarily reinforcing. There are several influential studies that support CBT. There's a 2017 meta-analysis by Wang and his colleagues, and it found that CBT significantly improved anxiety symptoms and remission rates compared to no treatment, and even beat fluoxetine head-to-head. So it suggests that CBT can be more effective than some SSRIs, and overall CBT has a lower dropout rate in most studies, and fewer side effects, of course. However, the side effects of SSRIs in studies of anxiety tend to be generally mild. Now, the Child Adolescent Anxiety Multimodal Study, or CAMS, was a landmark trial, and it included a combination of CBT and sertraline, sertraline by itself, CBT by itself. So acutely at 12 weeks, the combination of CBT and sertraline had the highest response rate, about 80% according to their measures. And that was significantly better than CBT alone, which was close to 60%, or sertraline alone, which was about 55%. So all the active treatments beat placebo. The response rate for placebo in the study was about 24%. This low placebo response was actually important to demonstrate because at the time, people thought maybe watchful waiting would be enough, but this demonstrated that it's probably not enough. The study was continued more into the long term, and at 36 weeks, most of the acute responders, about 80% of them, maintained their gains. Now, CBT and sertraline monotherapy outcomes improved and then converged with the combined treatment because the combined treatment peaked early and then didn't change much. So kids got better faster with the combined treatment, but over time, continuing CBT and sertraline resulted in kids catching up with the others. But the combined treatment group maintained an edge for achieving full diagnostic remission from an anxiety disorder, whereas the others just caught up on remission rates based on a scale called the CGI-S scale. Now, for all anxiety disorders, but especially for specific phobias, exposure is key. So you're not going to medicate your way out of a specific phobia. And there was an aspect trial, and that's published in 2022, and looked at one-session treatment versus multi-session CBT treatment for specific phobias. And it included children aged 7 to 16 years with a specific phobia, and they were randomized to receive either the one-session treatment or the CBT. In the end, they found similar efficacy for both, which means that maybe shorter treatment can be just as effective for specific phobias. Now let's move on to pharmacotherapy. SSRIs are generally used first line for most of the anxiety disorders. But then the SNRIs, like venlafaxine and duloxetine, are often used, generally second-line medications. But if you're looking for FDA-approved medications specifically for generalized anxiety disorder, you have duloxetine, an SNRI, and escitalopram, an SSRI. And those are the only meds specifically approved in kids. There are a lot of other meds approved in adults. But for kids, duloxetine and escitalopram. Now for OCD, which some people consider to be on the anxiety spectrum, we have approvals for escitalopram, for fluoxetine, for sertraline, and for fluvoxamine, as well as clomipramine, a tricyclic. If you are relying on FDA-approved medications specifically for generalized anxiety in children, you don't have many choices. So it would make a good test question, but the FDA approval is not very useful in clinical practice, especially if both those medications don't work. A somewhat recent network analysis, this is by Dobson, Block, and Strawn in 2019, and it included 22 randomized controlled trials with a total of 24 different treatment arms, including 2,623 patients in total, showed that selective serotonin reuptake inhibitors, as a class, were superior at reducing anxiety. So overall, if you're going to choose a medication, start with an SSRI. Next came serotonin and norepinephrine reuptake inhibitors, along with alpha agonists, alpha 2 agonists, for the treatment of anxiety, because these also separated out from placebo, but not quite as well as the SSRIs did. The likelihood of treatment response was about double for SSRIs compared to SNRIs. Also, SSRIs potentially have an earlier onset and greater efficacy than SNRIs for the core pediatric anxiety disorders, but I'm not sure that this has been thoroughly looked into. Now, we have to remember that the FDA has a black box warning for all antidepressant medications regarding increased risk of suicidal thoughts and behaviors in kids and adolescents and young adults under 25. So monitoring is essential. So let me review real quick the medications. What is FDA approved for pediatric anxiety? We have duloxetine, also known as Cymbalta. It's an SNRI, and it's approved for generalized anxiety, ages 7 and older. And then we have escitalopram, aka Lexapro. That's a SSRI. It was approved in May of 2023 for generalized anxiety disorder, also ages 7 and older. Now, if you want to generalize from approvals for obsessive compulsive disorder, you might also try Prozac, Zoloft, Luvox, and anafranil. So that's fluoxetine, sertraline, fluvoxamine, and clomipramine, a TCA. It's also important to note that there are no medications specifically FDA approved for pediatric separation anxiety disorder, social anxiety disorder, specific phobias, panic disorder, agoraphobia, or selective mutism. But SSRIs are commonly used off-label for these, especially if the symptoms are rather severe. So before I stop talking about medications, I want to talk about something else that's a crucial point and might also be on the board. So a lot of medications that are used in adults for anxiety have not been shown to be effective in kids. Kids are not just small adults. There are neurodevelopmental differences in their brain structure, receptor sensitivities, drug metabolism, and psychosocial circumstances that all play a role. There are also some methodological challenges in pediatric trials. It's often said that kids have higher placebo response rates, so that can complicate things. It might be harder to separate out an active medication from a placebo in kids. So let's look at a few classes of medications that may be used in adults that really aren't used in kids. One is benzodiazepines. So these are effective for like short-term adult anxiety, but randomized controlled trial in pediatric anxiety disorders, not in procedural anxiety, which is different, have largely failed to show superiority over a placebo. So you can give a kid benzodiazepine before a procedure at the hospital, and that will help. But if they have an anxiety disorder, it doesn't tend to be all that helpful. And risks for benzodiazepines, of course, include dependence, if they're taking it for a long time, withdrawal, and there can be paradoxical reactions as well, like agitation or aggression. So these are not generally recommended for pediatric anxiety disorders and should probably be avoided. The next are the tricyclics, the TCAs, and I'm here excluding clomipramine for OCD. I'm talking about all the other TCAs. And they have been found effective for adult anxiety in many cases, but the evidence in pediatric anxiety outside of OCD is really sparse. So TCAs might be something you don't reach for unless everything else has failed. Certainly not a first line. Then there's buspirone, and it's FDA approved for adult generalized anxiety disorder. However, there are two large randomized controlled trials in pediatric populations in generalized anxiety disorder that failed to show superiority over placebo. Some people have argued these trials were underpowered, but all that means is that the effect size would be very small if you have to highly power your study to find it. So even if they did find a difference, it wouldn't be that big a one. However, it was generally well tolerated in kids, and of course a higher dropout rate than placebo due to adverse events. But it's not really recommended because it hasn't been proven effective, and in fact has kind of been proven to be not that effective. Next we have hydroxyzine, and that's an antihistamine with some anxiolytic effects. It's often given in adult generalized anxiety disorder, especially for acute anxiety. But there's really a lack of robust evidence for its use as a primary treatment for pediatric anxiety disorders. Sedation is a really prominent side effect of hydroxyzine in kids, and I've seen this effect in practice, so I rarely use it. It might have a limited role, like for acute distress or for procedural anxiety, but not so much as an ongoing treatment, for example, to take right before you go to school or something like that. Thank you for hanging out with me today. Today, I've reviewed pediatric anxiety disorders, which are very common, impairing, and require a developmentally informed approach. We've talked about diagnosing them, some of the child-specific nuances, and some of the evidence-based treatments like CBT and SSRIs to start. And these themselves have many considerations based on the age of the child. What the specific therapy will be is going to be a lot different for a child who is 5 versus a child who is 15. And when you start medications, you may not jump right to that in the younger children or start at very low doses if you need to. But in general, for moderate to severe anxiety, combination therapy often yields the largest and the most durable results. And then we have to be mindful that medications like benzodiazepines, most of the TCAs, buspirone, and hydroxyzine, which have recognized utility in treating adults, really generally lack much evidence or have what you could say a less favorable risk-benefit profile in children, and so shouldn't be really considered until other things have been exhausted. Until next time, I am Dr. O'Leary, and this has been an episode of Psychiatry, Child and Adolescent Psychiatry Edition. Nothing in this podcast should be considered personal, medical, or mental health advice.